Thank you all for coming. Welcome to the Schar School of Policy and Government here at George Mason University. My name is Greg Koblenz. I'm director of the Biodefense graduate program at the Schar School and also an associate professor. Welcome to the Schar School as well. And I want to thank Dean Mark Rozelle in the audience here for the generous support that is making this event possible. We're here for the launch of Lessons from the COVID War, an investigative report. This is a book that was 2 years in the making, but it was well worth the wait. It's already been widely heralded as an ambitious and comprehensive assessment of what went right and what went wrong in the U.S. Response to the COVID pandemic. And as you can see, I already have a copy of mine that I have used pretty thoroughly. You can get your own copy as well if you don't have one. We have books for sale outside. And as added bonus, both of our speakers who were co-authors on this book will sign your copy as well. And this is one of the benefits of having this event being done in person. So unfortunately, those of you who are watching at home online, you'll have to just order yours from Amazon or buy at your local bookstore. Let me introduce our two panelists. Andy Kilianski and Melissa Harvey are two of the 34 members of the COVID crisis group that just published this book, which only came out just a few weeks ago. I very much look forward to having a conversation with them, but don't worry, you will as well. At the end of the session tonight, there'll be a Q&A period, and there are microphones on the sides of the room where you can ask your questions as well. And then again, I invite you after the event to come out back in the reception area, purchase a copy of the book if you don't have one already, and get your copy signed by Andy and Melissa. So first, I want to introduce Dr. Andy Kilianski. He's currently the Senior Director for Emerging Infectious Diseases at IAVI, which is a global science nonprofit focused on providing equitable access to vaccines against emerging infectious diseases. Prior to joining IAVI, he was a senior scientist and program manager at the Department of Defense, where he led numerous efforts to counter biological threats, both internationally and within the United States. During the pandemic, he was part of the Department of Defense's COVID-19 task force. He received his PhD in microbiology and immunology from Loyola University Chicago, where he discovered virus-host interactions necessary for coronavirus pathogenesis. And this work contributed to the development of vaccine and antiviral candidates for SARS and for MERS. Dr. Kilianski also is an adjunct professor here at the Schar School in the Biodefense program, where he teaches courses for us on biosurveillance and on emerging infectious diseases. It's nice to have you back on campus, Andy.
Thanks, Greg.
We also have with us today Melissa Harvey, who has more than 20 years of experience in healthcare emergency preparedness, working in some of the nation's largest healthcare organizations and at the local and federal levels of government. At the federal level, she has led large-scale responses to infectious disease outbreaks, natural disasters, and mass casualty events. Until 2019, she served as director of the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. Following that, she served as the Director of Health Systems at the Department of Homeland Security. During the COVID-19 response, she was detailed to the FEMA HHS Healthcare Resilience Task Force, where she led the team responsible for hospitals. She received her Master of Public Health from Harvard, and she's a proud alumna of the George Mason School of Nursing. Yeah. Welcome back to Mason.
Thank you.
You both were working for the federal government when the COVID pandemic started in 2020. Andy was at Department of Defense. Melissa, you were at Department of Homeland Security. So let me start off by asking you to talk a little bit about your experience working at the federal level on pandemic response, both what that was like for you, professionally, but also how that affected you personally.
Sure, I'm happy to start. As Greg just mentioned, I spent time both at HHS, where prior to the pandemic for about 10 years, my role was to help prepare the nation's healthcare system for exactly the COVID scenario that we experienced. And there were certainly some challenges with that in terms of funding and keeping the prioritization of preparedness kind of at the forefront of everyone's mind when, it's really more of an insurance policy. You have to be ready, and then you can rely on your readiness. But if you're not ready, then it's like not having insurance when you get in a car accident. But that was, most of us that worked in the healthcare preparedness program would sit around thinking about various scenarios during those lead up years to COVID and thinking about what if there ever was a pandemic? What would the problems with the nation's healthcare system be? And if any of you notice me sweating a little bit right now, it's because the last time I was in this room was actually when the federal government rented out this space to run what we called the Crimson Contagion exercise, which was in 2019 and or 2018, I think it was. But either way, it was this room was packed with federal, state, local officials, all thinking about the exact scenario of what would we do if there was this, virus invader in the United States. How would we communicate that to the public? Would we shut down schools? How would our hospitals be ready? Would we run out of N95 masks and personal protective equipment? The exact same things that happened during COVID. And so it was certainly interesting sort of watching the pandemic kind of begin. I think most of us who were in this field kind of got a good sense right around New Year's Eve of 2019 into the next day, 2020, that there was something happening in China. There was a virus, and they had already determined at that point that it was not influenza. None of us really knew that hospitals were packed and that a lot of people were dying from it, but there was this novel virus that was not flu. So I think a lot of us were thinking, is it SARS 2003? Is it MERS? Like, what could this be? And then it became a little bit more clear sort of every single week, just when you're looking at all the different modular hospitals going up a couple of weeks later in China, that this is bad. Like, this is not your run-of-the-mill virus that's going to go away. This is going to be here. We live in a very globalized society. We can't keep it out of the United States. But the federal government was very, very focused on what we call containment, keeping this outside of the US and not really thinking about what do we do when it is actually here? How do we prepare ourselves to make the tough decisions on closing down schools and shutting down not everybody all at once, but small communities at a time where we can detect and find the virus and make sure that it's not this kind of blunt force instrument of complete shutdowns across the board. And so I think what was, for me, back to your question, what was the most challenging was sort of watching this unfold, but recognizing that we weren't taking the actions that needed to be taken in the time frame that we needed to do it for them to make a difference. So it became then now about March of 2020. I mean, things were at that point, the virus was in the US, there were Washington cases, New York, which is where I'm originally from, and had worked in the largest health system in the New York City area for many years. It was very challenging to watch this all unfold and not see the government kind of moving into a process by which we were attacking this, right? We were going after the problem hardcore. And so we spent the month of March really figuring out how to organize ourselves. I mean, like, is that really what you should be doing when you're really facing this head on? That's something that should be figured out a little bit ahead of time. Who's in charge? If we're going to move into a task force structure, what should that structure look like? And that really, again, didn't happen until CNN was at 24/7 coverage of this virus in New York. And then at that point, I'll just end by we were behind the curve from the very beginning. We didn't set ourselves up well and have the readiness in place to be able to quickly and transition into a response mode.
Yeah, so I'll echo a lot of what Melissa just said. Like Greg mentioned, my graduate training's in coronavirus biology. So working in the Department of Defense, working to protect our warfighters, when they're deployed abroad from emerging infectious diseases and biological threats. This was like prime time. This was, I think a small group of us who were working in emerging infectious diseases within the department at the time. We all saw very early that this was going to be impactful, right, for our warfighters who were deployed abroad. And really just the context in which, COVID-19 really evolved and unfolded. This was going to be a geopolitical shift. Things were really going to change, right? And whenever that happens, the Department of Defense is always sort of on the front lines. Fast forward to March 2020, when we all got sent home, I think when work started to become remote, I found myself the next day down in the Pentagon and working with the Secretary of Defense and the Chairman of the Joint Chiefs. And I, really was able to see up front that urgency, right? And the ability to move things quickly. And obviously the US military can do those sorts of things, but we can't do that internationally and within our country. So a lot of really fascinating things moved very quickly, and I think from a vaccine development perspective, which is my background, the U.S. really led the way for the rest of the world, and Operation Warp Speed, and really the Department of Defense had a huge part in that, right? And I was very fortunate to be involved in some of those activities. But overwhelmingly, I think Melissa and I feel this way, and our group feels this way. Things did not go well from an overall context. Our group's composed of an incredibly diverse group of really experts who are interested in this question of how do we go back and look at what we did right, what we did wrong, and really provide a foundation of knowledge to make smart decisions going forward about how we fix these things. Because the next pandemic is a certainty. It's going to happen. Hopefully we have some time to reconstitute some of our capacity, but it could be tomorrow. And we really need to have that sense of urgency when we think about preparing for the next pandemic. So overall personally affected, right, as a coronavirus guy, in a position within the department to make a difference, I don't feel great about it. I really, when I look back, and even today, we were just talking out at the reception, there's 1,000 people dying every week still in the United States from COVID. And so the pandemic's not over. And, yet we are, the reason we put this book out is because, a commission and things that we thought needed to be done to really get to the root cause of some of the issues that we had, right, didn't look like it was going to happen. And we're really losing that attention and the momentum to fix things going forward. So complicated set of emotions and impacts, I think, personally and professionally. But it was great to be a part of this effort to really give us a foundation to spring forward into how we fix things for the next pandemic.
Yeah. And I think it's fair to say that both of you, in different ways, are preparing basically your whole lives for dealing with kind of large-scale public health emergency, which we hope never would come, but we knew it was a matter of when, not if. But I'm curious, given all of your background and your training and education and expertise in either the biology of coronaviruses or in federal disaster management and health response, were there times when you felt that all of your previous training experience wasn't providing you were hitting challenges that you didn't have the answers to, or that what your previous experiences just weren't relevant to because this was a paradigm shifting event, or that the nature of this virus was particularly difficult or pernicious and really was kind of outside of your frame of what you had been kind of preparing for to deal with in this situation?
I could start. Yeah. So on the virus side, so SARS-CoV-2 really found every seam in how we would typically and how we were preparing for an emerging infectious disease event outbreaks here in the United States. Right. I mean, a lot of our paradigm for responding is identifying people who are sick, right? Providing testing to determine if they're sick with the disease that we're concerned about, right? And then providing non-pharmaceutical interventions, right? Like Melissa was saying, to really stop the transmission of these viruses in these local areas. And we had typically war gamed and thought about, diseases which had a case fatality rate of 10%, right? Or for the Ebola virus, for example, 50%, right? So very, lethal, very apparent types of emerging infectious diseases. And so, SARS-CoV-2, case fatality rate, right, depending on the course of the outbreak, between, 0.5 and 3%, at its highest. Asymptomatic transmission or subclinical transmission, so the ability for people who aren't outwardly ill to transmit disease. We're seeing the breakthrough infections for folks who are vaccinated. So, people who have a vaccine might still be able to transmit the disease to other people. Those sorts of curveballs, I really don't think were front and center in our preparedness plans and how we thought about the next pandemic unfolding.
I mean, I think for me, we always thought of, the response to a biological event in terms of, a framework of what we call the 4 S's, right? Do you have enough space to take care of people? Do you have the staff to do it? Do you have the supplies to do it? And do you have the systems to do it? And I think for the most part, we send people home from hospitals really early these days. To get admitted to a hospital, you have to be very, very sick. So there's a lot of space. There's a lot of space that we don't utilize every day. From the space side, I think we thought, yep, we're probably okay. And we know how to make other space and other kinds of buildings of opportunity. The staff side, I think we all knew we were not okay on the staff side. I mean, we're not okay on the staff side on the day-to-day taking care of patients. So certainly not going to be when there's a large scale surge. Supply, as I mentioned, there were enough exercises, even H1N1 in 2009 told us we were going to have problems with supply on the PPE end. The system side, again, we knew that public health and healthcare systems don't speak to each other. We knew that the IT platforms, it's almost, healthcare has very good knowledge and information about what's happening inside their system. But from public health, it's all, and still to this day in many places, happening by fax machine. So we knew the system side was going to be very, very challenging. The side I think that took me by surprise the most was the misinformation and disinformation side. We had always viewed the CDC playbook for how to communicate with the public and do risk communications about, being first on the message, being honest about what you know and what you don't know, as the rule book. And unfortunately, a lot of that didn't happen. We didn't communicate early in the federal government about what the risks really were and about what the threat really was. I think even in, late February, we were still saying there's a low risk to the United States, but we had cases here. So, we didn't really follow the rules that we knew about risk communication. And even though COVID was not a failure because of the partisan divide, it was certainly more that our policies and our lack of response in some ways led to that partisan divide. That definitely threw an element into this pandemic that I don't think many of us had imagined.
And I think to carry on a little bit on that last point, with a disease like Ebola, for example, there's a fear element, right? As there should be with contracting a disease like that, and right with the outcome, of a viral infection. With the sort of case fatality rate, landing where it did with COVID, maybe you knew someone who got pretty sick with COVID, maybe you had a family member who was severely affected. But I think over time, right, the really true fear factor lasted only a few weeks, I think, in 2020. And so it was very easy to kind of not think about it, right? Because maybe you weren't seeing the impacts every day from your, if you're the average American. And so that was just another, really confounding element to all of this, is that those NPIs and the role of public health officials, right? I think if the disease was a lot more lethal or a lot more outward in symptom development and really the course of the disease, I think America would have really sort of followed some of those pieces in the playbook a lot more easily.
Yeah, back to the, kind of the emotions question too. I think for a lot of us that have been in the space for a long time, as I mentioned, whether it was the exercises we did leading up to it, we knew the problems that we were going to face. And it was hard not to get caught up in just like the anger of it, in the sense of, I remember from my role in the federal government having to every single year go through the federal budget process and defend the budget that we had asked for. And every year, every time we asked for it, we got a budget cut. And I often got asked the question, whether it was from the White House Office of Management and Budget or Congress, what is the exit ramp for funding healthcare preparedness? This is a private sector responsibility. It's not a public sector responsibility. So when this was designed after 9/11, and now they should be ready. They should have bought the stuff they need. They should have done the exercises they need to do. Healthcare makes a lot of money, which is a huge misperception, I think, among many people. So they can fund their own preparedness. And so every year those budget cuts kept going down so much to the point where you had to say, is there even relevance to so many of these programs? And then you're watching, refrigerated trucks in New York City housing bodies from COVID. And you're like, it didn't need to be this way. There's a lot that didn't need to happen.
Yeah, so let me pick up on that, because the United States does spend more on healthcare than any other country in the world. Right, we've had enough exercises and things that we knew we weren't prepared, and yet we were still surprised by how unprepared we were. Right, we ran out of ICU beds, we ran out of ventilators, we ran out of PPE. What happened? What was it that was, to what extent was it kind of our healthcare system that had structural weaknesses, or what do you see the factors that kind of led to that outcome?
That's a great question. I mean, I think the bottom line is, we talk about a healthcare system. The bottom line is there is no system of healthcare here in the US. It's a conglomerate of either for-profit, not-for-profit, or public hospitals, hospital systems. And I'll say that's the only thing that has a capital S, is that it goes after their name, right? So, but they're not incentivized at all to work together. They're not incentivized to plan together, to prepare together, to respond together. We have massive competing entities that I'm sure all of you in the audience receive mail at your house from all the various different healthcare systems in this area, trying to get you to be a patient there. Healthcare spends a lot of time trying to steal each other's patients. So the likelihood that when we're in the middle of an emergency, that healthcare systems are going to kind of just say, well, how about you tell me how many beds you have available? And how about you tell me how many ventilators you have available? And now we're going to share each other's patients and move them around. It would be really nice. And I think there were some states that were very successful in setting up those kinds of capabilities at the beginning of the pandemic. And they did have a lot of information sharing and what we often call patient load balancing happening. But I would say those states, there were fewer of them than there were states that couldn't even figure out how to make that happen, despite being the greatest healthcare emergency in our country's history. So there's really a couple ways to do this. Right now, the reason that it doesn't happen is there's no financial incentives to make it happen, and healthcare is run by financial incentives. So you can do that by incentivizing preparedness and actually paying for it. You can do that by putting it as part of regulatory or accreditation kind of requirements, and really making those measures and standards uniform, so that one system over here is not very well prepared while the other system is just doing the basic minimum that's required by the Centers for Medicare and Medicaid Services. And then you can do that, if not that, by a willing collaboration of partners. And we've seen this in other industries that are competitive. The aviation industry has requirements from the FAA that they have to share safety data with each other. So you don't walk on a Southwest plane and say, I'm no less safe than if I walked on a Delta airplane. They share that information. There's a way to de-identify it through a third party and make sure everyone learns the lessons from each other before there's another crisis. We don't do that in healthcare. We do lessons learned and after action reports and various kinds of hot washes, but we don't necessarily look at a crisis, whether it's a mass shooting or a COVID response, and say what really went well and what didn't, because there's no requirement to do that, and there's no financial incentive.
I think from the federal perspective, and Melissa was, saw this firsthand, our disaster response enterprise is really built on regional sets of capabilities, right, that can flow into an area that's affected. That's how the strategic national stockpile is constructed for, our reserve medical supplies, as well as how FEMA and others, right, respond to disasters. And COVID came so fast and was, on both coasts really right away. And as a result, everyone was affected, right? And so you didn't have reserve capacity somewhere that you could move into areas that were affected. And I even think for a lot of our planning processes, when we think about the diseases, emerging in this country in certain, regions, that we still sort of had that mindset in terms of, well, we can stop this because we have extra capacity somewhere else that we can flow into these areas, right? And we saw very quickly that was overwhelmed because COVID was everywhere.
Yeah, and I think it all goes again back to metrics and how do you measure, aside from, we all know there were flaws in the reporting systems, and there was underreporting of cases largely because of the testing challenges that we had, or I'll just say the lack of testing. But we knew hospitals and just how surged they were. But again, without that requirement to share that information, there were very minimal federal resources that could be thrown at the problem, whether they were the DoD response teams or the HHS, ASPR, National Disaster Medical System teams. But it was very hard for federal officials to try to determine who needs it the most, right? I mean, there was more of a, I'm really surged over here, I need some help in my hospital, but it's like, are you doing worse than the hospital 3 states away? And who really needs this? And so back to not having data, not having good situational awareness systems, and not having any set of kind of metrics that really tells the story of what's happening and where we can put our very limited resources. It was kind of flying blind the entire time.
Yeah, and that theme of flying blind, I know, was kind of repeated throughout the book. And the difficulty of making good policy without good data. And we're at a policy school, right? So we like good policy, and we know you need data for that. And our situational awareness definitely suffered both initially when we didn't know enough about the cases that were in China, and then once the virus was embedded in the United States, how it was spreading, where it was spreading, what the hospitalization rates were, what the deaths were, and all that. To what extent have we improved our ability to have situational awareness of these kinds of outbreaks, or what's the area that needs the most work moving forward on that?
Yeah, I mean, I'll start and then turn it over to you, Andy. I think, as I mentioned earlier, healthcare has very robust information systems through electronic patient records. And the vast majority of health systems can actually sort of tell you what's happening inside of the health system. I work for a very large health system right now, and we have the capability to look at these kind of auto dashboards that are pulled from the back end of our electronic health record and find out exactly where beds are available across the system, exactly where certain kinds of COVID positive patients are, exactly where we might have ventilators. The electronic health records have a treasure trove of data. And that's honestly where healthcare is, where we create a lot of public health data. You come into the hospital, you get tested, you usually get your treatment there. There's two theories right now on how to do this. There's the theory that we need to do it what I'll call kind of bigger and more powerful than the way we've been doing it, which is public health gets a lot of manual data and has to now enter it into some kind of data system and send it on to the state public health and then to the CDC. Or, we can catch up with the 21st century and try to use the systems that we have and, find a way back to my earlier point of incentivizing and trying to really have that situational awareness that should be shared with public health and should be shared with all levels of government so that a lot of the crisis decision-making and the good policies can be made. But right now, there are some groups that are recommending, whether it be CMS or whether it be a third-party entity. We know the new CFA, Center for Forecasting and Outbreak Analysis at CDC. There is certainly some movement. It's just really sad that we're more than 3 years after this pandemic now, and we're not sort of coalescing ourselves into sort of one direction that we can get behind and make happen at this point.
Yeah, I will agree with that. I think from a surveillance perspective, we are better off. CFA is a great example. Some of the wastewater surveillance systems that have been put in place are definitely a step forward. I think the challenge is, even if we do generate data that's going to allow for us to have better situational awareness, I'm always thinking about how are you going to use that data and what sort of decisions is that data going to drive? The mis and disinformation environment creates challenges, I think, for any future NPIs or anything. So non-pharmaceutical interventions, and the ability to apply public health tools, like we did early in COVID. I think it's going to be very challenging to do that again if we have, a respiratory disease like COVID cause the next pandemic. And then from a, rapid response perspective in terms of developing vaccines and better diagnostic tests and monoclonal antibodies and other treatments, those triggers to start moving on some of those things, I still don't think we figured out exactly what those trigger points are. Right, so it's great that you can surveil really in a pathogen agnostic way wastewater, right, for potential infectious disease threats. But when are you going to use that data to make a vaccine or therapeutic against something that you might detect? I mean, so those trigger points, I think the delays in activating those points really, I think, contributed to a lot of damage here in the US and internationally, even though warp speed was great, right? We got the vaccines very early, could have been a lot earlier. And, when the vaccines, hit EUA for use in the public here in the US and internationally, there are already 1.8 million people who had died from COVID. And so, yes, we did move very fast, and it was, we got lucky in a lot of respects, but we're still way too slow. So, using those data and how they're collected and what decisions they're going to inform, I think we still have to figure that out.
I'll just add one thing to that actually concerns me a lot at the local public health department and state public health department level. And that is since COVID and largely as a result of the NPIs that were put in place and the public outrage after it, there are just a tremendous number of states that are stripping public health authorities And so I really do worry that we're actually in a worse place than we were at the beginning of this pandemic, not just for large outbreaks, but even when you think about the ability to quarantine an individual that might have extremely drug-resistant tuberculosis. Some states, we don't have that authority anymore, whereas we all had that authority prior to this pandemic. So we really need to think a little harder on this biosurveillance side, how it applies to the data, and then how it applies to, as you mentioned, our policy setting.
Yeah, and going back to Operation Warp Speed that you mentioned, Andy, that is one of the bright spots in the COVID response, and the book spends a good amount of time talking about that. But maybe you could just tell the audience a little bit about what made it that program successful in terms of actually developing 2 highly effective vaccines, mass producing them, large-scale immunization campaign. What made it succeed, and can we bottle that and do that again, or does it require a emergency situation like a pandemic to really
Yeah, so I'll start with the second part first. We should never have to do it again, right? We've learned that really by spending a lot of money very quickly in a way that is competitive with industry, we were able to get things that worked, right? So if we're ever in a situation where we have to redo Operation Warp Speed for some other disease, we're in a lot of trouble. And that means we haven't learned any of the lessons from this pandemic. I think, we were very fortunate, again, that the mRNA platforms were efficacious against COVID-19. That was certainly not a given. And, the mRNA vaccines didn't work for a lot of diseases that they were looked at. And so the fact that they worked and were in a manufacturable, scalable system and platform, it was great. And it was very advantageous that the US government had invested in those technologies before. And then really it was so successful, not because there's some like secret science sauce or anything like that. It was, we are going to fund multiple competing platforms, and it's okay if some fail, right? Inevitably in vaccine and therapeutic development, you're going to get many candidates that, look promising early, right? But might not have the efficacy that you really want in a vaccine or therapeutic. And so by doing that, right, everyone was competing for, first access to the market, right? So there was a financial incentive there for the companies that were involved. They were backed by a lot of really insurance money from the US government, so that if their program failed, right, they would be compensated for the research and development and the efforts that went in. And then if they succeeded, right, all of that investment early on would be covered by the US government. So, really a confluence of factors allowed for us to move quickly, but really it was money and it was contracting authority, right, to work with these companies to move things forward. When we are in the current situation, right, and you look at, well, how could we have done things better for Operation Warp Speed, for example? We didn't keep doing it, right? Very short-sighted to say, these mRNA vaccines, this is the best solution we're going to have. And evolution and things like that, maybe we're not as concerned about, right? And so now the booster uptake, in the US is something like 15% of the country is fully vaccinated. We're continuing to see variants of concern in evolution. And that's going to keep happening when we have that low threshold of fully vaccinated individuals. So, I think the market's sort of spoken, and that we have 15% uptake of boosters. The companies aren't really incentivized, right, to do further research and development, to do further clinical trials, right, to really pivot to future variants. So it's a challenging, market, even in, COVID, where we have billions and billions of infections, right, for the pharmaceutical sector to be incentivized to continue development.
I'll just add a couple of points on that. I mean, while the vaccine portion of Operation Warp Speed was highly successful, I think it just demonstrates if you don't throw the same amount of effort and funding behind it, we really struggled on the treatment side of things. And so yes, we have Paxlovid and we had the monoclonal antibodies, but that has not been nearly as much of a success as the vaccine portion has. And the other point I'll make too is the vaccines were wonderful. If you don't have an operational capability to deploy them, then it doesn't matter how good your vaccines are. And we were very, very fortunate with some of the expertise and understanding of local pharmacies and retail pharmacies and the capability that they could bring. One, highly skilled individual at the CDC is the reason that many of you probably got your vaccines at a local drugstore pharmacy or a CVS or Walgreens. But that was not the original plan inside the federal government for how to distribute vaccines. It was that the vaccines would go to the public health departments, and the public health departments would vaccinate, 100% of the US population in like a week or something like that. And it's just, we have to, again, think a little bit more about how we do the day-to-day and integrating some of our kind of preparedness response into what our normal day-to-day is. Where do you normally go to get your prescriptions or your medications? So we have to, again, figure out how to better operationalize the great scientific knowledge and tools we have. Otherwise, it almost renders them moot.
And speaking of public health, it was quite striking in the book to read about how the American public health system was really designed back in the 1890s, right? And so we're relying on this public health system defense against a global pandemic that was constructed, the foundation was laid in the administration of Grover Cleveland. And, my son just took the AP US history exam, so he can tell me who Grover Cleveland is, but I have no idea who that is. And it's striking that we've got 21st century vaccine technology, we have 19th century public health institutions and structures. Can you speak about how that manifested itself during the pandemic and how that caused issues for us?
Sure, absolutely. And maybe we'll start at the top and go down, right? So the Centers for Disease Control and Prevention were supposed to be kind of more like federal guidance and policy setting. And yes, they have the Epidemic Intelligence Service that is, deploys out when there's a contaminated salad bar in a community that makes a handful of people really sick to try to figure out what the source and the origin of that is. It was not intended to be an operational entity that was going to lead the United States through a large-scale health emergency. Much of our public health enterprise is led by our states and local health departments that I can honestly tell you, having worked with many of them, none of them look the same at all whatsoever. We often hear, if you've seen one local public health department, you've seen one local public health department. And that's entirely true. You have some states where even if they have local public health departments, it's a centralized state, which means that, the local public health department is perhaps doing kind of the tactics on the ground, but all decision-making happens at that centralized state level. Other states, it's 100% local. Your local public health department has 100% authority to do everything, and the state health department is really there to receive funding from the federal government and push it out. So, we have to recognize that every community in the United States is local, and what works in Alaska is not going to work in New York City. But at the same time, the lack of standardization and the lack of being able to streamline some of this really makes it challenging to put out federal guidance on how to respond to health emergencies, sort of no matter what type it is, whether it's something as extreme as a pandemic or even a much smaller outbreak.
Yeah, I don't have too much more to add than that. It was very well put. I think we can go back and look a little bit at the data question that we had. If you're really able to lead with information, I think it makes the sales pitch, if you will, for public health intervention a lot easier, right? If you have a very informed public health apparatus in a way that's easy to communicate to your state or local area, then the reasons behind the decisions, I think, are a lot more interpretable by the communities, and that's something that absolutely we have to be thinking about. In this information environment that we live in, right? Leading with facts and numbers, right, that are collected by trusted individuals, I think, is going to be really critical.
So one of the kind of the core organizing principles of this book is that we've been fighting a global war against COVID for the last 3 years, and that war as an analogy is obviously prevalent throughout the book. But there are other examples. There's an analogy to the US public health system being like an orchestra, where you have to have disparate entities working together in perfect harmony. There's a comparison of the vaccine development as a Formula One racing, and where every minute, every second counts. So I'm just curious, how did the COVID crisis group decide to use war as kind of the main analogy, and what do you think the benefits of that approach, and are there any drawbacks that you see to that choice?
I'll start. My background is I'm a healthcare provider. I'm a nurse, and people always say, an emergency nurse. So people always say, you know, emergency departments are on the front line. So we often use a lot of war analogies, but it doesn't make many of us in healthcare super comfortable, right? We don't see ourselves as kind of war fighters at all. It's not what we do every day. What I sort of really liked about the war analogy for this book, though, is sort of it walks you through all stages of the pandemic. If you've got, you know, in this case, a nation state or just an individual actor that's looking to pose a war on you, it starts, you get some intelligence that that's happening, you start to mobilize, you start to figure out how to keep that threat outside of your country. And then if you can't, and eventually it does come into your country, you start to figure out how to fight the war on your own turf. And that really is very analogous to kind of how the war against COVID really should have happened in very discrete steps that obviously then blend into each other. What I also like about the war analogy is the way we fund our readiness for wars is we don't hesitate to spend a lot of money on aircraft carriers, on submarines, on various different kinds of technologies that honestly I know nothing about. We spend a lot of money on them, and most of them probably don't get used very much. We don't do the same thing for our readiness, whether it's on the public health or the healthcare side. We don't do a lot to invest in the countermeasures and vaccines and drugs that there's no private buyer. None of you are going to go to your doctor and ask for a script for a smallpox vaccine. That is inherent government responsibility should we ever need it. But we don't spend the amount of money we need to think about health security as a national security threat. And there are a lot of countries that are thinking about it that way. And so if we can't shift our mindset more to that concept of we need to prepare for a health security event the same way we prepare for other national security events, we're probably going to find ourselves in the exact same situation that we're in right now during a future pandemic.
Yeah, I think the war analogy is appropriate, right? If we frame right these future infectious diseases, right, as adversaries. And that's how we have to think about these things. I mean, you know, pandemics can be beaten, right? They can be prepared for, right? And there's definitely a playbook to be able to do that. You know, and I think when you look back in America's military history, for example, there's a few really good examples of times that we got things wrong. And that's really framed how we've prepared, right, our country. Pearl Harbor as an example. I mean, so much of the US, you know, defense and national security budget is so that Pearl Harbor never happens again, right? And you know, Pearl Harbor, 9/11, Sputnik, you know, there are these few very defining moments that have shaped budgets and planning cycles and policies. We need to have that approach for the next COVID-19, really for this COVID-19, because you know the pandemic is still happening, but really for the next event that's going to catch us by surprise. We need to make sure that we're ready.
Okay. This is my last question, although as you can tell, I have lots more, but I did promise you a Q&A session, and I know we have lots of eager Biodefense students and Schar students who want to ask you questions. So this is my last one. You know, this book is 300 pages long, and it does cover a lot of ground, but and it is very thorough. But obviously, right, it's still there's still a limited number of pages. And so, you know, you guys had to leave some things out, or there are things that just did not get sufficient attention from your perspective. So I'm just wondering, like, what is it that's missing from this book that you know, maybe at the sequel or in a future edition, you'd really like to see more attention paid to, you know, because COVID has affected, you know, every facet of our lives, our society, our economy, our country, globally. So what is it that is, you know, missing that you would like to see in this book or the future versions?
So, I mean, from my perspective, the book offers, you know, roughly 10 very poignant lessons that are absolutely true. And I think, you know, all of us very much agree with. If you look at prior reports that came out of commissions, particularly the 9/11 commission report, it offers a blueprint for not just sort of what were the lessons, but how, if we implement them, would we get ourselves kind of out of a similar kind of situation next time or prevent a similar situation? There's a lot came out of that 9/11 commission report, the NCTC, how we reformed our intelligence community, how we do airport screening. A lot of that has changed as a result of that. While the lessons in this report are certainly accurate, they don't necessarily point you to exactly how to go about changing for the future. And that was really a function of, as Andy said earlier, our intention was to have a full commission. Commissions, as you know, in this highly politicized environment are not really looked upon favorably right now. But that's really what we would have garnered from being able to do more than just roughly 300 listening sessions that were mainly about how to organize ourselves for a commission. They were not really the exact questions you would ask should you have had one. And that's what I think is really missing is sort of, as I mentioned earlier, that coalescing around a set of ideas and giving us that blueprint for the future on how to go about implementing.
Damn, Melissa, you stole my answer.
Sorry.
And that's exactly right. I think our group is very unique in that everyone is very do-oriented, right? I mean, we've got a group that really wants to help fix things, right? And this is definitely a foundation of information that will help ask those questions and think about the next steps. But yes, and I think in the sort of scope of the book, like you said, it's already 300 pages. We decided to not get into prescriptive or pseudo-prescriptive fixes to some of the issues that we highlighted. It wasn't really our remit necessarily because we weren't a commission with, full access and backing of the US government, for example. But I think a future iteration, or at least seeing some of the potential solutions that are highlighted by the issues that we found in this report, get actioned on. And that's really, I think the key to all of this is, we've seen some policies that have happened since the onset of the pandemic. We've seen some budgets be formulated. We've seen some reorganization within the US government. But it's not from a complete foundation of knowledge, right? Because no one has really looked and said, okay, let's line up everything we did, what we did right, what we did wrong, what worked, what didn't work. And let's use that knowledge to inform how we're going to influence policy and budgets and planning in the future. So yeah, Melissa stole my answer. I think that those next steps aren't necessarily present. But again, I think that this report gives the foundation to really make those decisions about what to do next very well.
And if there are any doctoral students in the audience, there's a lot to be done still in this field. So there's a lot
dissertations
of
to be written. Yes.
Exactly. And I have to say, I learned a lot from this report. I've really learned a lot just from you two sitting here and having this conversation. So thank you for
Of course.
your comments.
Thanks for having us.
So I'd like to open up the questions to the audience. So there's microphones on either side. Please feel free to head over there now. And when you ask your question, please let's have your name, your title or affiliation, and an actual question with a question mark at the end.
Oops. Yeah, William King from Booz Allen Hamilton, retired general in the Army doing this business for about 30 years. Fantastic. I'm looking forward to reading your report. I haven't read it yet, but you talked about a commission, like a 9/11 commission. And in fact, we've had one that's been in existence, republished this report. It's called a bipartisan commission, commission on biodefense and pandemic preparedness. And in fact, they publicized their 86 recommendations. And yet we still don't see traction on the government doing a whole lot about it. We've published 26 national strategy documents in the last 18 months, all highlighting the same things that we saw for Ebola, the same kind of things we're seeing with Marburg, the same things we've seen with one. My question to you, what's the catalyst that's actually going to force us to do something? Since a million American citizens' death as a result of this wasn't big enough, and we've already seen some reversing of efforts with CDC no longer accepting some of the reporting.
You want to take that one, Melissa?
I wish I had a good answer on the catalyst, right? I mean, I think, I really look at this and, we're often asked, well, why wasn't there a commission? And why wasn't there a commission? Because, to put it really simplistically, people already knew who they wanted to blame, right? The Democrats blamed Trump. And then the Republicans blamed either Fauci or China or whatever it might be. And so, there is a lot to learn from this, but it's become so highly politicized. And I think obviously that's why there isn't a commission. A lot of the great lessons that you pointed to have not been implemented. people are over this, and it's going to take, sadly, a group of the willing now, because you can't use the tragedy of the crisis.
Yeah, and the fact that some of the more bipartisan committees in Congress, right, weren't able to move some of these things forward, right, is really concerning. And when you have that kind of legislative logjam, it affects everything from policies to government structure to budgets. And in this environment that we're in, with a lot of other international crises going on, I think we're rapidly approaching, if not already there, the opportunity to really do this the right way might be gone. So I think based on us all talking here today, right, the bipartisan commission, which unfortunately, right, is retired individuals for the most part, of people who aren't currently serving. We need to think creatively about how we can do this and force change, right, without maybe that leadership intent to do so. Whether that's the private sector, right, whether that's us thinking creatively about public-private partnerships that can enhance these things. Yeah, I think we've got to get creative in our solution set.
Thanks. Okay. This side of the room?
I think they were in line first.
That's okay. We're just gonna.
Hi, my name's Olivia Parker. I'm a master's student in the Biodefense program here. So I, like most of us who weren't, hard at work stopping the pandemic, was watching those daily briefings with the president and the vice president and Dr. Birx and Dr. Fauci, et cetera, which I'm sure were not always like representative of the work you guys were doing. So I'm wondering if there is and maybe this is, I'm sure it's in the book and I look forward to reading it, but if there's anything, I guess one thing you could publicly correct the record on, what would it be?
So I'll go first. I don't know about publicly correcting the record, but I think one of the opportunities we really missed was that everyone was at home, right? Everyone was watching those daily briefings. We didn't educate enough in those opportunities. So I work for the DoD, and so one of the shining examples of DoD communicating potential threats was back during the Cuban Missile Crisis, right? And there's a great example of an intel analyst at the time who would get up there in front of the nation, right? Because it was, on all public television, with a map, right, showing America where these missiles were in Cuba, right? Talking about, what the threat means and how the US government is solving this crisis. We didn't lead with that information, that education first, right? I think if we used those few weeks where everyone was glued to their TV, right, for those daily briefings to talk about coronaviruses, right, to really highlight how typically coronaviruses are airborne viruses, right? And we need to be thinking about this, to talk about, what we know and don't know coming from China and elsewhere. I think just leading with education and a foundation like that would have really helped.
I would just add to that. I mean, again, nothing to necessarily correct from those briefings as much as I don't know how explicitly honest those that were doing the briefings were about just how much we didn't know and just how much was evolving. And so, I often think back if we had said, we don't know if masks work, but we're going to look into it. And then when we came back with the determination that they did, it wouldn't have been seen as a flip-flop, right? It would have been seen a little bit different. And so I think, that gets back to that CDC risk communication book that, I said, and one of the first things that they worry about is, be credible, be right, be first at the message, and be honest about what you know and what you don't know. And that was, again, those principles just were not followed across the board.
Thank you.
Hi, Raj Boya, no affiliation. I have a couple of questions. Well, I was in India at the time.
Let's do one question to start, and then
Okay.
once we get through everybody, then.
Yeah.
you can ask more.
I was in India at the time, and I was trying to see whether I could get a vaccine, that was made in the US. Sent tweets to the Secretary of State, the White House, and the US consulate in India. Absolutely no response. And I read in a newspaper that the US government does not provide vaccine shots to US citizens residing anywhere on the face of the planet, except in the US. So do you see a change happening down the line if it were to happen again, something like this?
Unfortunately, I don't know that side of, State Department policy enough to be able to comment on that.
Well, so in my current role, I think about vaccine equity a lot. right? And access to the developments that we're leading here in the US or elsewhere, really being accessible to the entire world. I think one of the huge reasons we're still feeling the effects of COVID here in the US is because we didn't lead with that equitable access to vaccines and therapeutics up front. And it's very clear, right, in a pandemic, borders mean very little, right? And really without a collective effort, both domestically and internationally to solve those problems, we're going to continue to do that because we can't isolate ourselves from whatever the next pandemic might be. There were some efforts that were led by nonprofit organizations that really made a dent in some of those challenges. But I think one of the main lessons learned, and it's highlighted in the book quite a bit, is that we aren't in a vacuum in these sorts of crises, right? And it really is an international response. And sure, US taxpayer money, right? US government has a responsibility to protect our citizens, and we should absolutely do that. But we need to ensure that the development and progress that we are making is available to everybody. Yeah, again, that's I think a logistical challenge, really probably only. I mean, when you look at even distribution of vaccines here in the US, it was not perfect, right? And it took a really long time to optimize. And I think in that shuffle, likely things got dropped out, and that might have been one of them. And really, the logistics behind moving these vaccines all over the world is something that we still have challenge with, especially the mRNA vaccines.
Hello, everyone. My name is Alan. I'm a Schar student, international security major, graduating this month. My question is, what is the panel's assessment from a policy perspective about China's net zero COVID policy? And I guess I'll do a secondary question real quick. With intelligence reports talking about the origins of COVID-19, what is the panel's assessment of the origins, whether it was lab leak, meat market, or combination?
So first, remind me of the first question again.
What was your assessment of China's net zero COVID policy?
So I would love to know more, to be honest. I think maybe not even enough time has passed to understand, civil liberties aside, right? But I don't think that's anything that we're ever going to implement here in the United States. But those more, strict policies in terms of COVID transmission and infection, I don't really know if we have a good understanding, from a variety of metrics, whether it's outcomes from COVID, number of cases and deaths in China versus here, impacts to GDP and the economy and general well-being of their citizens right after those. I think there's some really good research questions there in looking at it really from an unbiased perspective, right? To see, if we do have some measurables that we can point to say net zero was bad or net zero was good. I think that's an open research question.
I think we can say, though, that there are other countries, other democracies that did not have nearly as strict policies as the net zero policy that did incredibly well.
Yeah.
And those are certainly worth looking at, and many of them are mentioned in the beginning of the book. South Korea being one of them. Some of the European countries that, because they placed that heavy emphasis on testing, they were able to really contain the spread within the country and really know where their problems were.
Exactly. On the COVID origins question, I think it's a really complex one. I mean, when you look at some of the intelligence assessments that are out there, we don't know. I don't know if we're ever going to find out the answer. I think just based on what we know about coronaviruses, right, and really the ability of animal reservoirs to harbor coronaviruses that are readily, adapted to human infection. I think it's more likely that SARS-CoV-2 is from a natural origin. But really our book addressed this really not as, what's the origin or how do we find out the origin of COVID-19 or the next pandemic? It's why can't we find out the origin, and what sort of information networks and connections have to be made to be able to determine the origin of the next pandemic.
Great. Since we're getting short on time, if I could ask each of the remaining speakers, ask your question, and then the panelists can respond to them collectively.
Hi, so I'm Kimmy Ma. I'm a PhD student in the Biodefense program here, but I also work for the Association of State and Territorial Health Officials. So I'm very familiar with HPP and with FEP. But what I think I noticed serving at ASTO is that there was no contact with international ministries of health or experts from international countries. And the reason that that struck me is before I worked at ASTO, I was also at an international biosecurity organization. And I have had someone say to my face, who is the US to tell us what to do or how to build our capacity when you guys are doing so poorly with the pandemic? And so my question is, how do you see the US rebuilding its reputation as a thought leader?
Hi, I'm Danelle Harbin. I'm an adjunct at the Schar School. I'm actually part of a team of subject matter experts that are doing the New York State after action. In fact, I was interviewing people today. Sorry. So, yeah. One of the things we keep on hearing with the interviews we're doing from high-level decision makers is the lack of guidance and direction from the federal government, which left New York and many other states in a hyper-competitive environment. You combine that with federalism, and you had big states buying things and getting things that the smaller states weren't able to. And so how is federalism and those artificialities that were caused at the very high level of the federal government going to be combated for the next one?
Yeah, hi, my name's Phil Thomas. I'm an adjunct faculty member here at Schar. I teach global food security. You know, the issue here is WHO. You know, you'd say this is a global crisis. We're part of a global system. We have the World Health Organization. How can we strengthen our relationship with WHO and make WHO more of a vital part of dealing with this type of crisis?
Okay, so 3 very simple questions that you can answer in 30 seconds. Go.
Yeah, wow, where to start on all those? Maybe I'll start with the the last one first. I mean, WHO for years, I think it's been recognized that they are really not an operational entity. And so to be able to truly respond to whether it's a pandemic, whether it's a small Ebola outbreak in Western Africa or Eastern Africa, I mean, there needs to be more of an emphasis on operations. In some ways, it was modeled a little bit after the CDC, which we recognize, that's a much more macro level. On the micro level here in the United States, the CDC had the exact same challenges as the WHO did on a global scale. So it's really kind of defining what is the function of the WHO as a UN entity. Is it meant to be operational? And if not, is there a different organization that needs to take its place that can do those operations? To your question about guidance on the federal level to the states, I couldn't agree more with that and the challenges that New York State and New York City and other all the states, frankly, had kind of competing with each other for supplies on the global market and others. And so I go back to just kind of one thought on this, and that's that for years we really promoted through the hospital preparedness program and other federal programs, this concept of thinking about it not just as a state, but a region inside the United States. And I say that too, because I felt a little bit sorry for New York, having come from there, been watching it unfold there. But in my role in the government, I was able to communicate with healthcare systems just outside of New York State, in Connecticut, in actually, Long Island and the city were the ones most impacted at the time, but in upstate New York and some in Pennsylvania. And when you're fighting a war, it's really hard to take a step back and say, all right, let me look at this from the bigger picture. And there were hospital beds, there were plenty of ICU beds with furloughed healthcare workers and others at home, an hour outside of New York City where all this crisis was unfolding, but there wasn't the situational awareness and the ability to see that. I don't know about you, but I'd rather be cared for in an ICU in Connecticut and have to take a 40-minute ride, up 95 than be cared for on a ship in New York Harbor. And so it gets back to that sort of broad situational awareness. I think, yes, the federal government can do a much better job providing guidance than it did. But at the same time, we have to have the states kind of being willing to cooperate with each other in ways that really we haven't seen happen in the past. To the question about the international ministries, what I would say to that is we actually had to rely on a lot of international ministries because of how poor our response was. So we use data from Israel, we use data from the UK, we use data from all over the place to make decisions because we didn't have our own data. And so they are absolutely right to be asking the question of, who's the US to tell us what to do? And, I think we ranked ourselves as #1 most able to respond to a pandemic, and look how that turned out for us. So you make an excellent point there.
I'll go inverse order. So yes, on the international engagement piece, I think the US government right now is working to claw that back, right? And a lot of that is going to be collaboration, cooperation, right? Exercises, sort of like we did here with the report, of a common understanding of what went right, wrong, right, and how to fix things together. The second question on the federalism. So we were actually talking with Dean Rozelle out in the hallway here, but before we all came in, and he actually has a paper, a study out looking at different countries that have a federalist type structure, right, and their successes or failures with COVID. And so I don't know enough about the topic, but he does, and so I will direct you to that report. And then the final question was WHO. Yeah, Melissa nailed it. Not an operational entity. There are many challenges, working across borders, across regions, responding to infectious diseases, right, that take manpower and money and things that the WHO doesn't really have, right, and it really isn't set up to have. And so I think as we're thinking about the role of the CDC and operationalizing public health here in the US, I think a lot of those same things will apply to the WHO.
Certainly.
Well, thank you guys for a very enlightening discussion. We covered a lot of ground, even more than I had thought we would, and it was just fascinating. So please join me in thanking our panelists. And don't forget, if you don't already have your copy of Lessons from the COVID War, it is available for purchase outside, and both Andy and Melissa will be available to sign your copy. So we will see you out there. Thank you for coming.
Thank you.
Thanks so much.